Good afternoon, everyone. I would like to welcome you to today's webinar, Autism Spectrum Disorder and Fragile X Syndrome, Co-Occurring Conditions and Current Treatment by Dr. Walter Kaufmann. I'm Jayne Dixon Weber, the Director of Education and Support Services here at the National Fragile X Foundation. I have a couple housekeeping items for you. These webinars are made possible by your donations. Thank you for your ongoing support. We have about a 20 to 30-minute presentation today, and then we'll take questions for the remainder of the hour. Please use the question bar on the right side of your screen, and you can type in questions at any time. Today we have Dr. Walter Kaufmann. He is a clinician and a researcher with a focus on developing novel therapies for genetic disorders associated with intellectual disability and autism. He's the director of the Center for Translational Research at the Greenwood Genetics Center in South Carolina. Before arriving there, Dr. Kaufmann was a professor of neurology at Harvard Medical School. His research uses a multidisciplinary approach to understand the basis of cognitive and behavioral problems in children with genetic disorders associated with intellectual disability and autism spectrum disorder. He's one of the leaders in the study of autism in Fragile X syndrome. He's a member of the Fragile X Clinical and Research Consortium and has published more than 200 journal articles. He's also served on several editorial boards as a reviewer of over 90 scientific journals. Welcome, Dr. Kaufmann. It's a pleasure to have you with us this afternoon.
Hello, everyone. Thanks, Jane, for the kind introduction. This is my first webinar, and I am very excited to be here and to talk about this important topic. The focus is a publication that came out in June in the Journal of Pediatrics. And I want to emphasize that this publication was possible thanks to the participation of many of you in the project called Forward, which is funded by the Centers for Disease Control. And this is a very important project taking advantage of families attending clinics, which are part of our consortium. We collect data and we try to understand the most important issues that affect individuals with Fragile X. Initially, it was a project about children. We're expanding this project to also adults with Fragile X. And certainly autism, the diagnosis of autism, or the new terminology, autism spectrum disorder, is a common one in Fragile X. Here you can see that there are different metrics, different ways to measure the relationship between Fragile X and autism. Number one, Fragile X syndrome is the number one, the leading cause of genetic cause of autism. Depending on the study, anywhere between 2 and 6% of children with autism are diagnosed with Fragile X. On the other hand, if you look at from the Fragile X perspective, about 40% of individuals with Fragile X are diagnosed with autism or autism spectrum disorder in our clinics. That proportion is higher in males than females, as in some way is reflected in the general population with autism, but is probably higher in Fragile X because males are more affected than females. Now, the central issue about doing this study was to answer the question, what happened when a child with Fragile X is diagnosed with autism? What difference does it make? So we focus on identifying the different neurological and behavioral problems that were affecting those who got the label, who got the diagnosis of autism. Two issues that are illustrated here is that in general there are more problems, but this is also age dependent. As you can see on the left side of the slide, in children, those who are ages 3 to 11, there is a higher proportion of a variety of problems. Those are mainly hyperactivity and ADHD type of symptoms. However, anxiety is not more common in those who got the diagnosis of autism, while on the other hand, the problem is more prevalent in those who are older, those who are in the teenage years. So in general, there are more higher proportion of individuals who have neurological and behavioral problems, and they tend to be more severe also in those with autism, but there is an age dependence. Specifically, there are problems that are much more obvious during adolescence. I'm going to get to that in a minute. This slide shows that seizures are more common at any of these two ages, two groups of the children, 3 to 11, and the teenagers, 12 to 21. Those who got the diagnosis of autism had a higher frequency of seizures. In terms of sleep, the difference is much more obvious only in those who are older, in the teenagers. And that's what the slide tried to show. It doesn't mean that sleep problems are not present in those who, without the diagnosis, they are actually common, but they are more common also in the adolescents, in the teenagers with Fragile X and autism. The behavioral problems that affect individuals with Fragile X are diverse. There are different types. So we examine each one of them, but only a few were clearly more common in those with autism. In the case of children, disruptive and aggressive behavior is more common in those who got the diagnosis, as well as ADHD symptoms and hyperarousal. And as you know, hyperarousal is this excessive response to sensory stimulation. Is typically auditory, but it's not only auditory, it could be other sensory modalities. Other behavioral problems were not more common in those with Fragile X. When you look at teenagers, one of the things that is clear is that anxiety is more prevalent in those, more frequent in those teenagers who got the diagnosis of autism. And that is maybe a little bit of a surprise because we see anxiety also in children. In any case, anxiety is a very important problem, particularly social anxiety is a very distinctive feature of Fragile X, and adolescence represent a particularly challenging time period in anyone's life in terms of social interaction. So important, being part of the group. Social life really is a major part of adolescence. So that is probably one of the reasons why it's more prevalent or more clear, higher prevalence at this age. In addition to looking at what type of behavioral problems or neurological problems the children had, we look at also use of medications, and we found what we expect, that since disruptive behavior, aggressive behavior is more common in those with the label of autism, the type of medication that are used for those for treating those conditions tend to be more, the use of those tend to be more common with those with autism. We're talking about medication what we call atypical neuroleptics. Some of them you know by their brand name, like Abilify and Risperidol. Those are medications that are typically used for those behaviors. So that wasn't a big surprise, and is a confirmation that some of the behavioral problems are more common in those who have the diagnosis of autism. Now, in addition to that, we look at what type of non-pharmacological treatments, meaning no drug treatments, are those children with autism receiving. And that we look at everything that is under the therapy and service label. And what we found is that in general terms, the children with the diagnosis of autism tend to use or receive more services, and that's very clear for services across the board for those in preschool, at preschool age. But by the time that the children are in a school from K to 12, which is 5 years and older, actually we were a little bit surprised that while many services are more prevalent more frequent in those with the diagnosis of autism, some services that you expect to see in children who were diagnosed with autism were not more prevalent and more frequent. And we're talking about services that had to do with autism, like social skills, applied behavioral analysis, what we call ABA. And we were surprised about that, and we tried to understand this and to compare with what happened in the general population with autism. And that's what the slide is showing. For instance, ABA, which is a type of behavioral therapy which is widely used in the autism field, in children who are in the pre-K age segment, those who have the diagnosis of autism, 26% of them are receiving those services. But those who are older, who are in the K to 12 in the school period, only 16%. And both numbers are lower than what we see in the general population with autism, in which is about 36%. So that was a surprising finding. Many of the findings that I presented to you before were not a complete surprise. We had suspected them, but because they were done in a study with smaller samples, not as large as Forward, which for this purpose of this study had over 500 individuals with fragile legs being analyzed, is important that this data was confirmed. But this is completely new, this information about utilization of services. So why to do this? Well, because we want to make sure that we understand what it means to have the diagnosis of autism, and what are the problems that children and teenagers with fragile legs and autism can have. So like I said, some of those were already reported in a smaller study. But the other thing of having a larger study, confirmatory study, a study that could be more definitive, is that we can have information for planning. And how this is used. For clinicians who are seeing children with fragile legs, knowing this information is important because we can emphasize the type of problems that they have to pay attention to. An example is in children who get the diagnosis of autism, let's say at age 3 or 4, be aware that soon after that, they may have aggressive behavior, disruptive behavior, and perhaps a way to deal with the situation is to make sure that the environment of that child is one that makes less likely that they will display those behaviors. Our ultimate goal is to have good quality of life for these children, and not necessarily is to write more prescriptions. It's to have management of the environment, to try to create the condition by which the individual can be better adapted to his or her own situation, whether it's a school, home, or what we call community, going shopping, going to recreation activities, playground, etc. So this is helpful for clinicians, but it's also helpful for clinicians and other therapies who provide services which don't include medication. And to make sure that we get appropriate treatments, it's very concerning that while they are getting more ABA when they are very young, they are not getting that in the same proportion when they are older, when they are in a school age. So this is actually something, that information that we can use when we are interacting with the schools where these children go. And in clinics, we do that. Many times we're involved in the IEP process. We're involved in advising the family. And then you can think also in terms of bigger policy. We may go at the state level, even at the federal government level, to explain the type of services that individuals with Fragile X, particularly those who get the diagnosis of autism, need. So this is planning at the local level, helps with the management of the children, and management could be more preventive. And also it helps at the sort of big picture, the type of thing that advocacy group like the National Fragile X Foundation do. So because the diagnosis of autism is so important, we have been concerned about how good are we doing. And DSM-5, which is the abbreviation of the sort of Bible of diagnosis of behavioral problems, mental health issues, go through multiple revisions, and the most recent one was published in 2013. It's about 4.5 years old. And we have been looking about how DSM-5 version number 5 is doing in terms of diagnosing. And we're beginning to be concerned about the quality of the diagnosis. Are we doing a good job? Is the diagnostic criteria that was released in 2015 adequate for our population? We have always been concerned that the intellectual and behavioral challenges of our children with Fragile X, may lead to diagnoses that are not accurate, either under-diagnosis or over-diagnosis. For full disclosure, I was a member of the committee that issued these guidelines, and these guidelines, like anything in science, are work in progress. So what we have started as a follow-up to this work and relationship with this study that I just reviewed, beginning to look at how can we improve the diagnosis. So as part of Forward, also this very important project, we're collecting data on a couple of autism-related measures. This one is the social communication questionnaire, and the other one, the social responsiveness skills. The names are not so important as to tell you that they are measures of autistic behavior, and we're looking at in which way that data can improve the diagnosis. We have made some evaluations already of how well these measures, which are mainly for screening, but we can use them as supportive measure for diagnosis. They are not doing very well, so we are working on improving them and incorporating them to the practice in clinics. So this is something that can be applied in Fragile X clinics, and hopefully not only that, we're going to publish a paper on the subject, so the clinicians who are seeing children and teenagers with Fragile X and autism, or Fragile X in general, can, who are not part of Fragile X clinic, also learn about this and become more tuned to the challenge of the diagnosis of autism in this population. So I am a fast talker, so I think that I have gone perhaps even faster than I expected. So that's all what I wanted to mention today, and so I'm ready to begin the discussion about your questions, clarifying what I presented. Thank you.
So Walter, we have our first question in, and it says, Dr. Kaufmann, thank you for your presentation. What would you recommend as current diagnostic best practice for ASD in children with Fragile X syndrome?
Hi, Jane. Is there an issue going on? I'm sorry. I didn't mean to interrupt.
No, I think everything's okay from here.
Okay, I'm sorry. I'm muting myself again.
No worries. Thanks, David.
We're working. That's a good question, and I think connects to the last slide. And we still recommend for clinicians to use DSM-5, but to try to incorporate as much information as possible, to try to to be as strict in terms of applying criteria. For instance, to make sure that the diagnosis is not influenced by the communication skills, the level of communication skills of the child or teenager or even adult, because that is not a factor that shouldn't influence the diagnosis. It's not the level of communication skill, but rather the use of the communication skills, how they are used for social interaction and communication. Another concern that we have, that's a general concern about a variety of genetic disorders that go along with the label of intellectual disability. But specific to Fragile X, we think that anxiety could lead to potential overdiagnosis. So to make sure that the symptoms that are taken into consideration for the diagnosis are not being influenced by anxiety, hyperarousal, this exaggerated response to sensory stimulation could be another factor. So taking into consideration the type of behavioral problems and the type of cognitive problems that the child or the individual with Fragile X may have, and not making sure that they are not the one influencing the process of diagnosis. I think we're not yet ready, but we will be ready very soon to recommend the use of a modified social communication questionnaire and social responsiveness scale. We are going to publish which items for those scales are important, because the scale were developed for children with autism in general, or at risk for autism. And again, they could be affected by this problem that I just mentioned. So we have selected through a process of very careful review which items of those scales should be used. And for instance, we have gone from 39 items in the SCQ to 25. I don't remember exactly the number that we ended up for the SRS. The original 65, I think, went down to 30 something. So there has been a reduction of the items. So when we have that ready, we're going to actually recommend the use of that to our Fragile X community, but also by publishing the data, this recommendation is going to be available to the general developmental disorders community.
Okay. It looks like it says they're using the app, and is this the way to ask presenter a question? I have replied, so if you want to, where you're writing that, your question, I can see your question. So if you want to go ahead and post that again, or if you want to post your question there, I'll be able to see it. So Walter, one of the questions that a parent sent in was, they have found that something like using a sensory diet, or incorporating sensory aspects throughout the day, they've read that it's been recommended for a lot of people with Fragile X syndrome. So something like that, is that true for when you have an autism diagnosis too?
As I mentioned, children who have the diagnosis of autism tend to have higher frequency of sensory problems. So definitely they tend to have more of that. Any intervention that deal with sensory processing is going to help. It depends on the particular child or teenager, because some of them don't have the problems at the same level of severity. But if the sensory issues have been identified and a specific therapy has been implemented as part of that, it will certainly make things better. You have to think that the core problems in autism are about social communication interaction, plus these what we call restricted and repetitive behaviors. That's the core, those are the core symptoms. And we have worked very hard. I mean the autism and developmental disability community have worked very hard to identify treatment for the core symptom of autism. Unfortunately, we don't have them here. That has been a frustrating long path, but everything that can be done to modify other behaviors is going to make the coping with communication problems, with restricted and repetitive behavior better. So an individual with Fragile X and autism who has sensory problems, the sensory problems are diminished. In general, any intervention that is trying to reduce, minimize the social communication impairment is going to be more effective. And overall, like I mentioned before, what we intend is to improve quality of life. So it's going to make easy, being very concrete, it's going to make easier for that individual to be in class, perhaps to go to a shopping mall where there's a lot of sensory information. I call it the Starbucks effect. I mention it that way because if you enter a Starbucks, one of these coffee shops, there are people screaming what they are ordering, there is music, there is so much sensory information that for many individuals, not only with Fragile X, but individuals with other disorders that have sensory problems, it's very difficult to manage. If we try to modify, to some way ameliorate that, we are going to make more likely the possibility that that individual, that child could be in that type of community setting. So definitely any treatment of these associated problems, from ADHD to aggressive behavior through anxiety and hyperarousal, are going to make a difference in terms of improving the overall quality of life and even the autistic behavior.
I see. So, well, speaking of anxiety, so what type of strategies do you recommend for addressing anxiety in children with Fragile X and autism?
Like any treatment, had to be very much tailored for the child. Some children can respond, particularly older children and who have better communication skill, may be able to respond to some type of modified cognitive behavioral therapy, which is a treatment that is used in anxiety. Others can respond to play therapy. Other type of behavioral interventions are also effective, dealing with anticipating anxiety leading situation. So they are going to go to the doctor. So preparation for those events, preparation for transitions. So there are a variety of strategies that can be used and in the general category of behavioral management, all the way from issues with scheduling to more complex therapies. I cannot give a single recipe for everyone with autism and anxiety because there's so much of a difference. Now, medications may be needed also, and certainly we tend to use medications that are used in the general population for anxiety, and those tend to be what we call SSRIs. And actually we know some seem to be more effective in Fragile X, and I will use those. Sertraline seem to be more effective than others. We don't know why, but we know that. And also even some of the medications that are used for treating aggressive behavior seem to also help with anxiety. One of them in particular, aripiprazole, the commercial name is Abilify, seem to be more effective than risperidone for dealing with anxiety, at the same time dealing with aggressive or disruptive behavior. So there are a number of strategies that can be applied. I always recommend, and most of us try to do as much as we can without medication, but when the medication is necessary, we use it. Having said all that, of course, we're not happy about all the options we have, and that's the reason why we keep doing clinical trials to look for medication that could be more effective, and specifically for Fragile X that can go to the root of the problems due to FMRP deficiency in the brain.
And so you would do, like, I mean, I know that there's some strategies online, for example, addressing anxiety. And so what I'm hearing is that if you have a child who also has a diagnosis of autism, that it's even, not more important, but, just as very important to really figure out those strategies and what work for your child, because of the impact that autism can have on the Fragile X syndrome.
That's correct. I mean, I think that everything that we can use to minimize the load of problems for these children is critical, because that will make them more engaged in the type of therapy that we're trying to use for their core problem. I mentioned that in the study published in June, we were surprised about seeing that children who got the diagnosis of autism are not using or not receiving social skills therapy in greater proportion than without the diagnosis. That's perplexing. But in order to take advantage of that social skills therapies or any other type of hero problem, we need to try to minimize all the other problems that they have. So we are more proactive about treating anxiety, treating hyperarousal, like I mentioned before.
Right.
ADHD, it will help. It will definitely help. It's all very customized, because as you can see, the range of problems that a child with Fragile X and autism can have are numerous, but they are not necessarily all in the same individual. So it has to be really focused on what are the problems of this specific child or adolescent.
Gotcha. Excuse me. We're going to switch gears just a tiny bit, and he says, in your experience, when do children with Fragile X typically get diagnosed with autism? Is there an age when the autism symptoms begin to display in children with Fragile X syndrome?
I don't think that we have that data, and I don't want to give my impression only, because exactly with the study like the one we published in June, we were trying to go beyond small cities. One thing that is true is that some children are diagnosed with autism before they are diagnosed with Fragile X. The average age of diagnosis of Fragile X continues to be about 3.5. So some children are diagnosed with autism before that, during the course of evaluation by the pediatrician in early intervention programs that end by age 3. So that's a group in which the diagnosis of autism is before the diagnosis of Fragile X. Those who receive the diagnosis of Fragile X, I would say that if they go to a place in which there is a lot of experience with individuals with Fragile X and other developmental disorder, they get the diagnosis relatively shortly after that. For the most part, it's continuing being true that between age 4 and 5, in general, the diagnosis of autism is much more obvious. We want to make the diagnosis earlier than that, but I would say that the lapse between the diagnosis of autism and the diagnosis of Fragile X and then autism is rather short in the hands of someone who is very knowledgeable about the population. And remember, we want the diagnosis, but we want the correct diagnosis. We don't want everyone with Fragile X to get the diagnosis of autism, because that happens when the people are not familiar. So we want to have the right diagnosis, and that's the general picture. As we move with the improved diagnosis approach, we're going to look into these issues. This is an excellent question, and it shows you how much we can get from this study like forward, and we can look at every issue. So this publication that I presented has led to other studies, and we're going to lead to more follow-ups to try to get deeper and deeper into the issues that affect the individual with Fragile X.
Gotcha. You know, here's a question, and actually I do get emails on this one too, Walter. He says, my child is not technically does not technically have autism, though he has many similar traits. But in order to receive certain benefits through the school system, it's like a switch gets flipped on when you have an ASD diagnosis. I'm torn over the ethics of pushing for an autism diagnosis when I can get more services. And so it's kind of, what's the sentiment in the medical community to go ahead and labeling my child with autism just to get more services?
This is a very important question. And this dilemma is not only a dilemma for parents, but also for clinicians. Because we want the best for our patients. And we struggle about providing a diagnosis that we may think that is not accurate, but is the only chance to get services. Right. And I think it reflects the problem with the system. And it's a very, very important problem in the United States, but it's not only restricted to the United States. I was earlier this year in Sweden, and I was discussing with my colleagues in Sweden the situation about the diagnosis of autism in general, not only in Fragile X individuals with intellectual disability, and it's the same situation. And that's a different healthcare system. I think we had to find some way to provide what a patient needs without being so strictly attached to labels. And this is coming from someone who wrote the label. so I think that we shouldn't lose perspective that the most important thing is what the particular individual needs, and whether all the symptoms are there to get a particular label or not is important for the big picture, organizational services and other things, and we need that. But if someone has social communication problems, but the restricted and repetitive behavior, the second component of the diagnosis of autism, is not there, we should provide the treatment for the social communication problems, and not to be so focused or fixated on the diagnosis. There is a problem, there is an impairment, we need a solution. And the question has a lot to do with policy and the organizational services. I'm going to tell you the truth. We clinicians sometimes give the diagnosis of autism because we're so worried that our patients are not going to get the services. But we know that by doing that, we modify the statistics, and we get, at the end of the day, whoever needs to plan for services having incorrect information is not good. So we have to have different approaches to this. With the concern that we have about the diagnosis of autism in Fragile X and other genetic disorders, we're beginning to think about getting other diagnoses that are such that point out to the real problem of the child, and we need to be proactive about saying, if a child gets the diagnosis of social communication disorder, yes, it doesn't sound like autism, but that child needs the same services as someone with autism in that area, social communication area. This is something that keeps me awake at night, and we need to do something about it. And this type of a study, like the one that we published recently, and the second one about the diagnosis of autism that I just mentioned at the end, are the studies that are going to provide data so we can go to the appropriate levels, whether it's legislature or other levels, to get a different approach to providing services.
Well, you know, Walter, thank you for sharing that, because I know that that's a really tricky thing. And so you know, I know families struggle with that in their, I mean, I've gotten emails, you know, my child really needs ABA, but unless he has a diagnosis of autism, you know, my insurance won't pay for it, kind of thing. So it's a tricky one. Okay, moving on to the next one. My child's anxiety and hyperarousal directly affects his ability to communicate. Whether it is Fragile X or his autism, both directly affect his ability to communicate. I don't understand how that would not increase communication problems in the DSM-5. I think that's what she's asking.
I really don't understand the question. I mean, certainly anxiety and hyperarousal are common. You don't have to have the diagnosis of Fragile X and autism to have both of them. All what we're saying in this study is that the frequency and probably also severity is greater if you have the diagnosis of autism. But you can have Fragile X with autism and having still anxiety and hyperarousal. And in both cases, it's going to impair communication. I don't understand what is the relationship with communication and with DSM, so I cannot answer that.
Let me see if she adds more in just a minute. I'll keep moving down my problems. Do you think the sensory processing problems are more of a contributing factor to the aggressive and disruptive behaviors in the ASD in Fragile X?
That's a good question, and we always try to understand why a child displays aggressive behavior. And to be honest, I don't think that we always have an answer, and we had to try to find the cause. But I think that also to be very cautious about over-interpreting situations. Probably the best way to make sure what is contributing to, let's say, aggressive behavior is to have long periods of observation and collecting data. That's what behavioral therapies do. Not only the ABA expert, which is one flavor of behavioral therapy, but other forms to collect data is this analysis. That's what ABA stands for, Applied Behavioral Analysis. So you look at the behavior of the individual and you try to see what is the trigger, what is causing the behavior. Definitely, we know that if you have communication problems, you get frustrated and you may display aggressive behavior because of that. If you have anxiety, maybe aggressive behavior, or what is labeled as aggressive behavior, is an escape response because you're so overwhelmed by the situation. You want to run, and in order to run, you push people around. It could be the sensory issue. I mean, you are so overwhelmed with that noise, with all that, so many things happening at the same time. And one way to say it's too much when you don't have the verbal abilities. Another way to change yourself, what is happening, could be aggressive behavior. So the answer is all the problems that affect individuals with Fragile X are common. Those that I mentioned: anxiety, sensory stimulation, communication problems. All of them could lead to some disruptive behavior, independent of whether they have autism or not. So a good behavioral approach to disruptive behavior or any other type of behavioral problem is to try to see what is the cause, or what is, if not the cause, is sometimes sound like it's such a big word, what seems to be triggering, what to see at least facilitating the behavior, and to try to deal with that as a way to decrease aggressive behavior. Unfortunately, all what I have mentioned involves time, involves having behavioral experts, and those behavioral experts are not available everywhere. Good quality behavioral services are not available everywhere. So unfortunately, what we try to prevent is not ending up on the pill, on the medication, as a solution to the problem. It may be the most short-term solution because the problem is so big that you had to deal with it right away, but it's ideally not the long-term solution. The long-term solution is some type of modification of the environment, modification of the way that the individual with fragile legs respond to the environment, and decrease the chances that aggressive behavior are displayed.
Well, I know that can be real challenging when you've set up a pattern. When you go to change something, it can take a while before that for example, the child, understands that, the environment is no longer going to be, you've changed the environment so that it's no longer going to be overstimulating or as overstimulating as it was before. So it takes a while to unlearn some of those behaviors.
Right. This is an important point because when behaviors, maladaptive behavior, what we call maladaptive behavior, inappropriate behaviors are displayed and in some way reinforced by the environment, it's very difficult to modify them. And when I was in Baltimore at the Kennedy Krieger Institute, and I began working on Fragile Legs in 1995, the inpatient behavioral unit had always a teenager, typically a teenager, nonverbal, many of them with autism, as an inpatient to try to deal with the behavioral problem, because that was the only way. It was no longer possible to do it as outpatient. By the time I left in 2012, there wasn't always someone with fragile legs. To me, it's an index that we are doing better. We have better behavioral services and earlier, and that's one of the functions of this publication, to say, look at this. If this child comes to you, let's say that a child comes to you with a diagnosis of autism, then an early intervention service, even before the Fragile X diagnosis, if that's the sequence, by the time that comes to your clinic, be aware that this is a child at very high risk to display aggressive behavior. So at the first report from parents or the school system or whoever is a therapist, let's try to take, to do an intervention that prevents the reinforcement of this behavior. And that can happen as early as 4 or 5. So yes, the trying to prevent the escalation of the behavioral problem is very important. And again, data as the one in the paper, reinforces the concept of being proactive.
Gotcha. Here's another one that's kind of tricky, I think. I mean, it's more of a comment, but then I have a question that comes out of it. So ABA therapies focus on compliance. Now, this is one parent's comment. ABA therapies focus on compliance and not mental impairment. For my son, we tried ABA from 3 to 5 years of age, and again at 7.5 years of age. His experience was a great increase in his anxiety because of the ABA. The ABA school did understand the Fragile X and anxiety of hyperarousal. We transitioned to a public school who did better with Fragile X, but they did not understand the autism issues. So then they went on to homeschool. Just a second, my computer jumped around. To teach, coping skills and teach at his level to help him understand. So what they found is that different placements did not understand the co-occurring diagnoses. But I do see that, kind of a question that comes out of that for a lot of parents is, so how do you adapt the ABA to someone who has Fragile X and autism? And I know Mouse and Tracy did write an article about that, but I mean, I'd love to hear what you have to say.
Right. I'm a physician, so I'm not a behavioral expert like therapists implementing ABA, but it's a very important question. If you are using ABA to extinguish some behavior or even, reinforcing or a skill, and the context in which it's applied is one that triggers anxiety or hyperarousal, obviously is not a good situation. So to me, ultimately, good ABA is an ABA that doesn't create new problems. Now, this sounds very straightforward, but it's not straightforward. For many children, it's not obvious that a particular approach that could be very structured and therefore anxiety triggering is inappropriate. But at some point, the therapist has to realize the situation. I think that if a therapist is applying ABA and doesn't know how to deal with anxiety in the context of autistic symptoms, needs to, to gain additional experience to take some courses, because it's not only Fragile X. Anxiety as a comorbidity, co-occurrence of autism is not only in Fragile X. The high prevalence is in the general population with autism. It is so much the link between anxiety and autism that now people who are doing studies, particularly testing new treatments in animals, models of autism, include anxiety as part of the symptoms that they look for in the animal. Is the drug decreasing behavior that are called anxiety in mice, as a way to make sure that the drug eventually, when it goes to human trials, we know that can deal with anxiety also. Anxiety is so close that anyone applying ABA for the purpose of dealing with autistic symptoms or autism-related problems, it has to be incorporated. Hyperarousal may be a little bit different, because while hyperarousal is also present in children with autism who don't have Fragile X, some of the elements of the hyperarousal you see in Fragile X are very unique. The auditory component. We have children who have tactile issues, the typical thing that they cannot deal with labels in the clothing. They have to have a sort of loose fitting clothing, things like those, and even visual stimuli can produce exaggerated response. But the auditory hyperarousal is a very unique Fragile X phenomenon, and so I think that I understand that could have been a little bit problematic. I mean, you make sure that you implement ABA not in a place that is going to trigger. It has to be a very soothing place. I mean, there are some sort of very straightforward way to deal. So I don't know if I had answered the question, but I think that, in my view, a therapist that would deal with ABA and autism had to be able to deal with anxiety, and to a large extent with at least certain level of hyperarousal. So I don't fully understand what happened.
Right. No, I think that's no. I'm with you. I think that's probably what does happen, is that they. I do hear that from parents too, is that some of the ABA does not take the anxiety, especially the anxiety, into account, and so.
And if it doesn't take into account, it's not going to be a problem. Those providers are going to have not only problem with children with Fragile X, but children with autism or other causes, because it's so common in autism, anxiety, that you need to deal with that. Now, one thing I want to mention, one thing that is different in Fragile X is the prominence of the social type of anxiety. All types of anxiety can be present, but the social anxiety is so prominent, and that it makes almost like a label of Fragile X. But again, autism in the general population, what we call idiopathic autism, is such a broad and diverse condition that you see many individuals who have social anxiety also. So I think that whatever was being implemented needs to be revised, because it's not going to only to fail for Fragile X, it's going to fail for other causes of autism.
I would agree. I would agree. For those of you who are still on, so you can go to our website, and I think it's called, the article we have is adapting adapting ABA for Fragile X or something to that effect. And if you can't find it, shoot me an email. A couple more questions, Walter, and then we'll call it a evening. What about the child that has missed the window of opportunity when they were younger to get that ABA behavior? And now the child is older and it's so expensive. So, I mean, there's a, you know, ABA wasn't around when my son was younger, and I often thought, you know, how would things be different if he had received it? So what can you give to parents whose kids are older now and they're just discovering ABA therapy?
Right. You know, we want to be ABA to be part of the early intervention, what we call early intervention in autism. But if it's not available, one thing that everyone had to remember, there is never a period in which you cannot do anything. So probably the type of effects that ABA has on a variety of domains, including cognition, are not going to be there because the developmental window was missed. However, any type of behavioral intervention, and ABA has become so closely attached to autism. I have to tell you, ABA was not initially designed for autism. It was designed for behavioral problems, mainly in dealing with intellectual disability, but it was seen as a way to modify behavior by having a sort of very scientific and a structured approach, like I said before, by analyzing the situation and trying to put a plan that makes sense to that particular individual. So behavioral interventions are never something that we should rule out, no matter how old is the individual. In fact, the story that I mentioned about the unit in Baltimore, those teenagers, typically 15, 16 years old, these big boys with fragile legs, autism, and limited verbal abilities, arrived to the unit after being on 4 or 5 different medications, and none of them seem to be, none of these combinations being successful in dealing with behavior. In the safe environment, they were taken off all medication. You cannot do that at home, but you can do it in an inpatient unit specialized in this. And we don't know what is working here. Maybe by the time that you end up with 4 or 5 medications, you don't know why the first one was prescribed. And they were taken off the medication, and the approach of collecting data and trying to modify behavior began. By the time they were discharged of the unit, many of them went with, you know, almost all with medication, but fewer than they came in. So maybe 1 medication, because the behavioral intervention had made a difference. So to me, and that was I can provide testimony that that's really possible. There is never too late to modify behavior. And while, you know, some of the gains that could have been achieved early in life may not be possible at 15 or 16, by modifying this other behavior that we report in this paper, we can make the difference in providing a better environment for dealing with the core problems of autism, if that's what the problem that this teenager has. So never too late to intervene. And I'm not saying this not only for family to feel better. This is actual based on experience, but also based on neuroscience. The brain, fortunately, still can be modified late in life. Not to the same extent that can be modified early in life, for sure, but it can be modified. You never lose the capacity to make a positive change. Now, the downside of that is that that's the reason why FMRP deficiency, which is the fundamental problem in fragile legs, is a lifelong situation, because you need the FMRP all the time for your connections in the brain to function properly. But the good side of that, the connections are constantly being reorganized and being in some way fine-tune is that there's always a window opportunity. So when we come out with a better treatment for Fragile X, whether it's a drug or non-drug, we know that even though if the trial was done in young children, that drug may be able to work to some extent in someone who's older.
Well, and I would agree with you. I mean, I've seen that. I mean, I think it's never too late, and I think that I've got an adult son, and he continues to learn, and so and he continues to understand like kind of the repercussions of his behavior. So I think that it's I think like all of us, I think we all continue to learn our whole life, and that's true for our kids too. So with that, Walter, I think we'll end on that question, and I would like to say thank you very much for sharing your expertise with us. It was very interesting and informative, and this was the first webinar we've had on that really discussed autism and Fragile X. So thank you very much.
You're welcome. It was a pleasure, and I'm glad I had the chance to cover this very important topic in Fragile X.
And if anyone comes up with another question, please email it to me and at Jayne at fragilex.org, and I will forward that on to Dr. Kaufmann. Before we end, I want to let you know about some upcoming webinars we have. We have one on the ABLE Act on October 11th. And we also have our annual webinar on medications with Dr. Craig Erickson on November 2nd. So watch your emails. Again, these webinars are made possible by your donations. Please go to fragilex.org and make a donation. Walter, any other closing words before we end?
I wanted to mention a website that for those who are interested in the issue of autism in general, and the website covers also Fragile X. The Simon Foundation, one of the major organizations for autism, has a website that is about news and is independent from the foundation. Essentially, all these studies, and this study that I just presented is going to be there, are digested and presented in a way that is objective to make sure that families who have someone with autism, as well as clinicians and scientists, can understand better the new research that is being done in the field of autism, including Fragile X and autism. So what's the website, Jayne?
I think so. You can, you can either, the website is spectrumnews.org, or if you Google Spectrum Simons Foundation, you'll also see it, because it's a part of the, it's a division of the Simons Foundation. Does that sound right?
Right, and maybe we will have a webinar in the future when we have a better diagnostic approach to talk about that, because we continue being concerned about the issue of autism, and this is only the beginning. And please don't forget to participate in Forward. This data has been possible thanks to Forward and thanks to all of you.
Thank you. That was great, Walter. Thank you for reminding people of that. And on that, we will end it. I appreciate all of you joining us tonight, and so thank you, and have a wonderful rest of your day.
Bye-bye.